Thanks a million for inviting me anyway, for starters. You've had a great program all week, so I'm delighted to participate. Well done to you all. So this evening I'll talk to you a little bit about the response to the clinical microbiology lab at COVID-19. So a little bit about me. My background, as Katie was saying, I've BSc in biomedical science, so I finished in 2013. I then went on to do a PhD in CIT with Bridget Lucy and Jim O'Mahony. And my career trajectory to date. So I started as medical scientist in microbiology in the Mercy, and about 2 years ago, I was promoted to senior medical scientist. So my current role involves laboratory work, staff training, validation, verification work, and most recently, I was involved in the establishment of the molecular lab inside the Mercy. So by way of a brief history of COVID-19, the clinical lab. So February 2020, we saw SARS-CoV-2 circulating in the community in Cork. At the time, specimens were being referred to for testing to the National Virus Reference Laboratory. In March 2020, we saw the validation of testing platforms, including our large-scale batch testing, which is available in the Mercy. And we began 24-hour, 7-day-a-week COVID testing in the microbiology, thanks to a dedicated microbiology on-call service. In April 2020, we saw the introduction of rapid testing platforms. So these were validated and available for urgent cases. Throughout the summer, we participated in further validations of reagents and media. And thankfully, we saw case numbers drop, but testing numbers actually increased as hospital activity returned to normal insofar as possible. And then in autumn and early winter, unfortunately, we've seen case numbers increase again. And this against the general background of an overall increase in testing numbers, especially with the schools back. We saw an increase in general respiratory virus illness in the community. So just a small bit of background about COVID-19. So COVID-19, so the CO stands for corona, the VI for virus, D for disease, and 19 for the 2019, which is the year of origin. So severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2 as it's known, is the causative agent of COVID-19. So just a little bit about coronavirus in general. So they're an enveloped positive sense RNA virus. And SARS-CoV-2 isn't the first one to infect humans. So other coronaviruses are implicated in a wide variety of human disease, from the severe end of the spectrum being SARS and MERS to symptoms more akin to the common cold, including HK1, 229, NL63, and OC43. So from early on, testing and tracing has been recognized as being key to the international strategy for the control of the virus, especially as we saw the first community-acquired case in Ireland being reported in Cork by Fowler et al. And CUH. So as I was saying, the initial response was led by the National Virus Reference Laboratory in UCD. Specimens were tested here, while laboratories and acute hospitals awaited testing reagents and kit. I have to say that during the initial stages that we're very lucky to have transport facilitated by a group of volunteers called Blood Bike South. So these are all volunteers. They were dropping the samples from patients up to the VRL all night and then going about their day job. Fantastic service and invaluable at the very start of all of this. So a little bit of background to the MUH for COVID testing. So we had a molecular lab installed only early this year, and myself and the chief medical scientist had undergone super user training on the new instrument as recently as the 14th of February. So this instrumentation was installed as a result of competitively attaining one of 122 Sláinte Care Integration Fund Awards. So the initial purpose was to improve patient flow through the hospital, reduce patient experience times, including waiting times, admission times, and discharge times through molecular screening for enteric and respiratory pathogens. For example, your influenza A and B and respiratory syncytial virus, and bacterial and viral etiologies of infectious gastroenteritis. Of course, the award was pre-COVID, so it changed. So prior to the initial introduction of testing in-house, so we had to source our extraction reagents, our PCR reagent or kit, and consumables. So this wasn't easy when the whole world wants them. We had to source some known patient samples. We had to finish retrofitting of our very new molecular lab, especially the installation of a Class 2 microbiological safety cabinet. So this was to ensure there was no cross-contamination of samples, and very importantly, that staff that were handling the samples were safe. So this wouldn't have been possible in the 5 weeks that it did take, were it not for the collegiality of our colleagues from within the hospital, across loads of departments, from household to maintenance to carpenters, electricians, and IT, and so on. Help from other hospitals, including the CUH and the Bonds, and of course our academic colleagues in CIT and UCC, who helped us out with, you'll hear later on about the buffer, but also with some consumables when things like plastics were in short supply, and partners in the industry were very generous as well. So once we'd sourced everything, we need to begin the initial validation. So we used the patient-derived specimens with known results. So these were sourced from the National Virus Reference Lab, microbiology in the CUH, the Bond Secures Hospital, and in-house patients who were positive. So the validation included testing the specimens over a series of runs or days. So the reason for this was to ensure that there was no reagent degradation with freeze-thaw cycles, or as the reagent was getting older. And we tested the samples blind insofar as possible. The VRL sent us out panels. We didn't know the result of those. We returned the results, and they told us if they matched or not. Next, we had to do some calculations. So these included the sensitivity, specificity, and some other important parameters of the assay, including looking for inhibitory substances and limit of detection of the assay. So this was done, believe it or not, over a very long weekend, just one, with staff staying on for hours to ensure that the results we were generating are accurate. And I'll go into a little bit more detail on this later on. So the results of the validation were all within our predefined acceptable limits. Therefore, we deemed the assay fit for purpose. We began testing patients in real time on the 23rd of March this year on a 24-hour, 7-day-a-week basis for the Mercy University Hospital and 4 other regional hospitals. We also helped out with the initial testing surge that arose in the community and nursing homes. It was a huge undertaking by all staff within the lab. So our molecular assay, it's called the C gene. It detects 3 genes of the SARS-CoV-2 virus. The first is the N gene. The N gene encodes for the nucleocapsid of the virus. So you can see that here in the schematic. The second gene is the E gene. This encodes for the envelope of the virus. And we know it's an envelope virus. And the third gene is the RDRP. So this encodes for the RNA-dependent RNA polymerase. So these genes are detected by reverse transcription real-time polymerase chain reaction, or RT-PCR. The PCR platform in MUH allows for the detection of SARS-CoV-2 nucleic acid, or ribonucleic acid, in up to 40 samples in a single run. A run takes approximately 6 hours. So the steps include the extraction of our nucleic acid, the thermal cycling result, and we result the sample as being SARS-CoV-2 RNA detected or not detected, and not positive or negative. But I'll go into a little bit more detail on the nuances of this later on. So a little bit about a timeline of a COVID test. So first of all, the swab is collected at a sampling center or hospital. The swab is collected from the nasopharynx. In our case, we request this from the nasopharynx and also the oropharynx. That increases sensitivity for our kit. So the swab is then placed into an appropriate medium, for example, universal transport medium or viral transport media. The swab is then sent to us. So the specimen is received in the lab. It's checked to ensure that minimal patient identifiers are present on the swab and match the request form. So the specimen is then assigned a unique accession number. Throughout the day, there are a number of molecular runs, and the specimen will then go on the next available run. And in the interim, the specimen is stored in a fridge to preserve the RNA of the sample. So now it's runtime. The specimen is brought into the molecular lab, and all manipulations are conducted within a biological safety cabinet, class 2. So as I was saying earlier, it's to ensure there's no cross-contaminations of samples, and also to protect our staff. So the first step is the addition of a lysis buffer. So this is a chaotropic agent which contains guanidine thiocyanate, important to keep it away from bleach. The lysis buffer inactivates the virus and also begins the liberation of the viral nucleic acids, RNA. So Dr. Scanlucy will tell you more about this later on, I'm sure. So the specimen is now ready to be processed on the molecular platform in use in the MUH. So as I was saying, we've got a system called the CG. We were lucky because this is the molecular system that we decided to get for our respiratory and enteric pathogens, as I was saying. But they were also the manufacturers of the instrumentation were also one of the earliest manufacturers to get CE marking, CE-IVD marking for the assay. And the manufacturers are based in South Korea. So we know that Asia had the first wave, I suppose, of COVID across the world. And we saw that South Korea had tested this. It was well established over there and was used to very good effect. It was the system that was mandated by the South Korean government. So the CGene system is made up of two instruments. So one is an extraction station, which is called the Nimbus. The other is an amplification system called the CFX96. And the Nimbus sample, the sample undergoes further extraction steps following your lysis buffer. So it's brought through graded alcohols in the presence of magnetic beads. This results, hopefully, in pure viral RNA for amplification. The Nimbus also makes up the PCR master mix and adds it and the sample to a 96-well plate prior to amplification. A PCR master mix is a concentrated solution that contains all of the components for real-time PCR. In our case, it includes a multiple detection temperature technology oligo mix, which is essentially your oligonucleotides, RNase-free water. It's got a buffer to facilitate the initial extractions, or the PCR, and a real-time enzyme as well, which includes our RNA polymerase there. So it also includes an internal control, and it adds this to the sample containing the master mix. So the purpose of our internal control is to ensure that the reaction for each analyte takes place. It's useful to determine if inhibitory substances are present. For example, with your feces sample, sputa and mucus, or very bloody nasal or pharyngeal swabs. So for these, if the internal control is positive, as it should be, and we've none of our target genes detected, we know the PCR reaction worked and that the result is not detected. So now that we've done our extractions and added our PCR master mix and internal control, the sample are ready for amplification. Amplification takes place on the CFX96. It undergoes a series of heating and cooling cycles, 40 for our system. Other systems vary. Generally, it's between 40 to 45, and that results in detection, or that this results in detection of our target nucleic acid, if present, through the generation of a signal. In our case, it's fluorescence. So the results are then viewable as a graph of relative fluorescent units versus the number of cycles, and also a list of targets with the CT value of detected for each sample. So I have an example of that here. So we can see for the sample in well C11 that the 3 genes have been detected. It happens that the colors on the graph actually are the same as the color of the fluorescence. And you can see those, they're listed up there. So FAM, Hex, California Red, and Quasar. So all 3 are detected. If we go down further, we can see that the CT values for each gene, so they're quite good. The E gene there is 28, the RDRP is 29, and the N gene is 31. So this is a reliable result. And it's important to note that our internal control is also positive there. So what do we do when we're reviewing the results? So first of all, we ensure that our positive control for the run and our negative control for the run are valid. Next, we have to review each sample to ensure that the internal control, as I was saying, is valid for each. Next, we have to determine if there are any targets detected. So what we do first is we check the cycle threshold, or the CT value for these. A CT value is defined as the number of cycles required for the fluorescent signal to exceed that of the background level. The CT value is related to the amount of target material present in the specimen, not directly, as there are many pre-analytical variables involved that I'll discuss a little bit later on. So if the CT value is low, and we count low in our lab as less than 35 following our validation, for all 3 target genes, we release the result as SARS-CoV-2 detected. If the CT value is high, i.e. greater than 35, and the patient has no history of SARS-CoV-2 infection, we repeat the sample using another platform to confirm. And again, I'll go into this a little bit more detail. So the time for processing each batch run, for a full run of 40 specimens, the time from sample preparation to result is approximately 6 hours. It takes approximately 1.5 hours to prepare our samples and reagents, including the addition of the lysis buffer and incubation in same. It takes 2.5 hours for the extraction and setup of the master mix on the Nimbus system, and approximately 2 hours for the amplification and review of results and the subsequent releasing of results. So the results release the requesting clinician. We do this via something called a laboratory information system. So the results are interfaced, we say, from the CFX96 directly to our LIS, Laboratory Information System. And these results are then sent to the requesting clinician. So our IT department in the Mercy liaise with the HSE IT to ensure that our system worked with the text result system. So if somebody is going to get their SARS-CoV-2 test, they get a text on their phone when the result is available detailing what it is. It's also important that the results feed into the HSE figures. So the results we see, the numbers we see Dr. Holden releasing every night, that we know that the Mercy is collaborating to that in real time as well. They're uploaded onto the system, I think, every hour. So following every run or every rapid test, that those results are uploaded in real time for easy collation by the HSE and the Health Protection Society. So I'd like to outline some laboratory challenges that came out of our COVID-19 testing. So they were under three kind of general umbrellas, really. The first being staffing, the second being supplies, and the third being technical. So the staffing specific issues include our Black Swan, White Swan system, training of new staff and existing staff on new technology, and the implementation of a new on-call rota. So during the initial stages of COVID-19, the staff within our lab were split into two teams. This was to try and minimize risk of COVID-19 spreading within the lab, and also to ensure continuity of service. So as a result of this, we had to adapt to some new working hours. We had an earlier start and a later finish. This resulted in difficulties for our staff, including childcare issues, disruption of studies, etc. So for training new staff and existing staff on new technology, this was against the background of split teams. So we had less staff on the ground, but we also had to ensure continuity of all other diagnostic services within the lab. We also implemented a new call rota. So this involved more training of staff and development of the rota itself. And we had to ensure there was no clashes between team members on team A or B, or Black Swan, White Swan teams. And finally, with the training, there were two super users, myself and the chief medical scientist, and one of us on each team. And it was very difficult to train other users because, as I was saying, we had a background of lower staff present on the ground for each shift. And there was also staff missing from being on call. We also had new staff that were hired during the pandemic, and they had to be trained as well on as many aspects of the lab as we could. The next challenge was supplies. So I'm sure you've read about all the shortages of reagents and media and so on, and swabs. So we've seen worldwide shortages of reagents. I'm sure you've read about the issues surrounding buffer, consumables, kit, and extraction reagents. The kit and extraction reagents, for the most part, are proprietary, which means that it's very difficult to get another company, near impossible really, to produce it, especially in mass. This resulted in further verifications and validation studies. We had to ensure that the replacement agents and consumables performed at least as well as those that we tested initially. So we completed at least 6 different validations of one instrument, including the initial validation, which included sample stability and storage, a new extraction reagent. So we conducted the national validation for that, and new lysis buffers. I think we've had 4 or 5 at this stage, and new media as well. So we had CE-marked universal transport media. We moved to CE-marked viral transport media, and most recently, the HSE procured a large amount of non-CE-marked media, which was UTM as well, and we had to do a fairly robust validation of that to ensure it was up to standard. So initially, we also had major issues surrounding the supply chain. Many of these appear to be solved now, thanks to the National Clinical Pathology Programme overseeing the distribution of kits and reagents throughout the country. It ensures that no lab has a stockpile, but equally well that no lab is going to run terribly short. There was one Friday evening where our extraction reagent was very low. We were going to run out Saturday morning and we would have had to suspend testing. And our extraction reagent had arrived in the country, but was being held in Dublin port. So our rep very kindly drove up to Dublin port to get the extraction reagent released, but couldn't make it all the way down to Cork because he had to go to another site. So I ended up driving up to Cashel to meet him, and he was saying that he had a very tough day and was really hungry, and was saying that we'd have McDonald's above in Cashel. But I didn't have the heart to tell him at the time. Everything was closed down, so he couldn't get a burger even for himself. But I think he used a chocolate bar in the garage, and that got him over the hump to get him home. Next, we had some technical challenges as well, including the introduction of a rapid testing platform. So once we had our high throughput system up and going, the rapid systems were starting to come on stream. The rapid systems are great. They allow for the system within an hour. They're closed molecular systems, so there's very little manipulation of the patient samples. You just add it to a cartridge or a pouch type system, and you load it onto an instrument. They're very useful, but they're limited by lack of scalability, price, and availability. And for all these reasons, they're only restricted to urgent cases. For example, your admission of patients to ICU, urgent or emergency surgeries, patients undergoing emergency aerosol generating procedure, or we'll say a patient attending ED who begins to deteriorate rapidly. Our initial system that we had turns out to be very short supply worldwide. So very recently we had to validate another rapid system as well, which we'll be going live with next week, I think. So another technical challenge. So I'm sure you've read about in the press about false positive. So there appears to be a narrative that they're making up a much larger percentage of new positives than is actually the case. So how do we in the lab differentiate between our false positives from samples with a truly low concentration of RNA? So as I was saying, the end product of amplification is a graph of relative fluorescence units versus cycles for each sample. So just looking at this, it's very difficult to differentiate. It's impossible to differentiate between false positives and true positives with the high CT. So what I did was I looked at all high CT positives for the last few months with one question in mind. Does a low final RFU for a target equate perhaps with the sample being a false positive? So here's an example of just the N gene for 4 different samples. So the first is a positive control. So we saw there that the final RFU for that N gene was around 1,000 RFUs. For a false positive sample, we saw that the final RFU was 650. Another false positive, we saw that the RFU was 600. And for a true positive, it was 700. So unfortunately, when we looked at all of these, that it was impossible with any degree of certainty to determine whether if a sample was a false positive based on the RFU. So what we do is that any sample with a CT value greater than 35 is investigated using another system. So we use our rapid systems in this case to ensure adherence to our strict turnaround times. So if the sample is also positive by another system, we report it as SARS-CoV-2 detected. However, if the sample is negative by the other system, we rerun it in our batch system. If it tests negative there and repeat, we'll report it as negative. But if it repeats as positive, we'll report as indeterminate and we'll refer the specimen to the VRL for confirmation. We'll also request a repeat specimen from the patient for analysis in the interim. So potential reasons for false positives. So there's a kind of a school of thought about the number of cycles that's relevant or not clinically, that perhaps nothing good happens after 35 cycles. So once you get to a high number of cycles, you have an increased chance of primer dimer. So this is a byproduct of PCR, where 2 primer molecules that have hybridized to one another because of strings of complementary base pairs in these primers. So this causes this false positive high CT value result. So this may be caused by multiple freeze-thaw cycles of reagents. poor primer design, or high primer concentration. This shouldn't be the case if they are commercially prepared, but the latter may be possible if there is an issue with their batch or lot number. And that's why it's important to record these errors, and we can feed these back then to the manufacturer. So potential reason for a true false positive, for a high CT true positive. So the first thing is the quality of the specimen. So the specimen should be a nasopharyngeal or nasopharyngeal combined swab. So if the swab is lower in the nasal cavity, let's say around the periphery, or oral instead of throat, you mightn't collect enough viral material for analysis. This is also one of the reasons why we report samples being not detected or detected, as opposed to positive or negative. Because we have very little, we have no control over the collection of the sample. And so we'll advise on the correct sample type, the correct site to sample it from, but we don't know what goes on with the sampling. So we're reporting for a particular sample that the RNA is present or not. Another reason for high CT true positive is if dependent on the stage of infection. So the amount of viral RNA present may be low at the onset of infection. So we saw a patient recently who was very early on the infection. They had a CT in the mid-30s for all 3 genes. The same patient was re-swabbed and retested the next day. And the CT values had decreased significantly, and they were in the high teens at that stage. Another thing we've seen is that viral RNA persists for a long time. So we've detected viral RNA in patient specimens who initially tested positive over 2 months ago. So the patient is obviously no longer symptomatic or infectious, but there's still a trace amount of RNA present in their respiratory tract. So for these patients, if they were previously positive or laboratory confirmed positive, that's fine, it's reported the same. But if we'll say they were symptomatic a number of weeks or months ago, and they turn out to be positive, we'll say as part of a pre-procedural screen, it's still important that though that information is fed into the national data and statistics. Although it's too late to perform any contact tracing, it's still important to add that data to our national statistics to get a true picture of the disease. So it's been an interesting year. So what next? So we're doing other validations. So for our batch testing system, we've got a new assay coming on stream shortly. It'll include a 4th gene, the S gene, which encodes for the spike protein. This will allow for increased sensitivity and specificity of our assay. And this new assay will also allow for concurrent detection of other respiratory pathogens, including your influenza A, B, and RSV, and some bacterial pathogens as well. So this will be very helpful as we try and triage patients, as hospitals are triaging patients coming into the winter, and to differentiate between influenza and COVID-19. A colleague of mine has recently completed the validation of the IgG to SARS-CoV-2, the spike protein specifically, assay. So this may be useful in occupational health screening. And perhaps we'll examine the role of antigen testing. We're unsure of the utility yet, as it's less sensitive than our current testing algorithms. And at the moment, in this stage of the disease and the severity as well, we'll say, of a patient being admitted to hospital with COVID-19 and not being known about it and pass it on to other vulnerable patients, sensitivity is key. So we're unsure of where this will fit in. It's rapid. You'll have the results within 15 minutes or so. But we're just not sure yet of the clinical utility in an acute hospital. So we've tested thousands of samples, I think, in the lab. In the Mercy, I think we've tested over 16,000 since March for COVID. We've done many validations and many more hours spent in the lab, so by all medical scientists. So the system is established and it's running well. So the vast majority of our tests, over 95%, are reported within a day. Most rapid tests are reported within 2 hours of receipt, while all other activities in the lab continue on as before. But successful implementation would have been possible without all the help from our colleagues across the hospital, in other hospitals, including the CUH and the Bonds, Blood Bank South, as I mentioned, the National Virus Reference Lab, CIT, UCC, Pfizer, our suppliers, the NCPP as well. And of course, all my colleagues in microbiology and our other labs within the hospital too. There's been a colossal effort all year. So as part of the establishment of our on-call rota, we had multidisciplinary on-call. So the microbiology staff would have manned the hematology and biochemistry on-call rotas out of hours. So the micro staff were repatriated to microbiology, and this meant that the other rotas were quite tight. So there was a huge effort from all across the board, really, to ensure that the service was maintained throughout this crisis. So on reflection of the whole thing, so we did everything we could to try and get the testing in place as quickly as possible, but we also ensured that the testing was of very high quality. So I suppose personally, I'm very proud to be a medical scientist at this time, and very proud of the team and our team across the country. So in the lab and across all labs, everyone pulled together and they just pulled out all the stops. We did extra hours, a huge effort, and constantly adapting to new practices and tests. So this obviously resulted in some personal sacrifices too for people. And we've seen extra workload and complexity of workload across the board. So it's not just scientists within the micro lab or the virology lab, but also in other disciplines and affiliated colleagues, including our surveillance scientists who've seen a massive workload increase as COVID-19 is obviously a notifiable disease. Our laboratory and hospital IT colleagues in getting the IT connections I was talking about, including the LIS setup. Our medical microbiologists, the clinical impact of this has been huge, and our infection prevention control nursing colleagues, just to mention a few. It's just been spread across the board. So I'd like to thank you for listening to me, and I'd like to answer any questions that you might have.
Great, that was great. Thank you. There's some questions in the chat, but just before we might answer them, I just want to thank you for your talk. I think it's really nice to be able to see, what happens to your swab once it's been taken. I think a lot of us, even if you get your bloods taken, they're taken and they're sent off and you do forget about them. But I think it's important to realize that there's a lot of work that happens behind the scenes. So thank you for just highlighting those. So do you have access to the questions, or would you like me to read them?
I do. I'd open them there. So how many cases of repeat positive test 2 months after first test? How do you know they're not infectious? So we've had a few, I'd say less than a handful now, so it hasn't been a huge amount. And how do we know they're not infectious? I suppose just literature reviews, the fact that the patients have no respiratory symptoms. So they're coming in as part of a preoperative screening. So as part of that, they're not meant to present if they are symptomatic. They are meant to continue with their procedure. So they're asymptomatic at that stage. Sorry, rambling, but so I know from flu work that viral RNA can linger for about 2 months. Yeah, you see, we haven't seen it with flu really, because you wouldn't be retesting patients for flu. It's only if a patient's symptomatic we'll be looking for flu. So with COVID, it's unusual that you are screening asymptomatic patients. So you are screening more, you're seeing more viral carriage than you would do with asymptomatic patients. And why is the RNA lingering for so long at the nasopharyngeal space? I have no idea. So it's very strange. So there's some patients will say that would have been very ill, that may have been ICU and that they're in the hospital for a long time. And if they're readmitted, we've seen this long COVID, they're readmitted and they're testing negative. And then you have people that would have had relatively mild disease and they're testing positive. So it's very strange, and I'm not quite sure why it's happening. There's another one from. How many samples would be done in a high throughput assay per day? Wouldn't that be the best way to go forward? Yeah, it is for the majority, especially the screening tests. So it varies. So we aim to do a minimum of 3 runs a day. So that's 120 in our site. Depending on workload that's coming in, we could do up to 200, and then we would have the other rapid tests going on as well. We've recently acquired a second C-gene analyzer, so our capacity should double soon. So this will be of great help to us going into the winter. But it's important that we do retain the rapid screen as well, so that patients are able to be moved through the hospital in a timely manner, and that staff will be able to step down PPE a little bit as well while they're dealing with them, especially if you're intubating a patient or any other aerosol generating procedure.
Okay, I actually have a question for you as well. There's a lot of talk in the news about, upping the number of tests that we're doing each week. Do you think
Mhm.
that the scientists in the labs are ready to increase the testing to the capacity that's expected of us?
I think so. We've gradually been growing capacity. So at the start, it was a bit of a surprise. So that we were going from zero to needing to do as many as possible in a day. Um, so I know that in our own site, I was saying we've got the second instrument, and we'll be getting we got more staff as well, and we'll be getting a few more staff as well, hopefully in the coming weeks. And I hope that is being replicated across the board. But I know that the National Virus Reference Lab and other reference labs, such as ENFR, have massive capacity. So if the diagnostic labs are overwhelmed, that the community testing and the less urgent cases will be referred back out to them. And Germany, then again, if we are absolutely, shoulder to the wheel again, Um, sorry, I see another one coming through there. Have you had any time to think about how you overcome staff shortages, new graduates in biomed science or other disciplines? So for the most part, we've been hiring medical scientists. So we two new medical scientists starting. But I know that in the coming weeks, we'll have two medical laboratory aides. So they won't be carrying out the work of medical scientists. They'll be assisting us. But I know that there is staff shortages across the country, but I'm unsure of what nationally they're planning to do to try and address that. I suppose the main thing is that we hold on to our graduates and recent graduates by offering, interesting jobs with good tenure, and that's something that is good. That's happened out of COVID. So we have seen that the majority of our graduates from last year, I think, have permanent jobs at this stage, and if not, they'll get them soon. So that is a great thing for our recent graduates.
Perfect. Another question. Keep you going.
Is it possible to retrain biology graduates to perform the test in order to help alleviate the pressure? It is. I suppose the issue with the profession is that to practice a medical scientist, it's going to be a protected title. So you need to register with Carew. So currently there's only 3 training programs in Ireland where you can be a registered medical scientist, so including UCC, CIT, TUD and GMIT. So there's certainly ways that I suppose we must look maybe at maybe conversion master's courses and so on. But currently there is no path to medical science to become a medical scientist from a general biology degree. But there are other ways that other science graduates are welcome to join, including being medical laboratory aides. We will still be conducting scientific work within the lab.